IVC and JVP, finger trap bros. So you got one vessel up top, one vessel on the bottom, and the heart in the middle. More specifically, the right atrium in the middle. And we're going to use these two vessels as proxies for volume assessments. Our IVC, we're looking straight down the middle. The way that I find it is just to put the probe right in the epigastrium and look straight down at the aorta. It's going to be thick-walled and pulsatile, and then I'm going to fan over towards the liver, and the next big vessel I see is the IVC. Next, I'm going to rock the probe so that I'm aiming up towards where the IVC dumps into the right atrium. And our perfect view is going to have IVC, hepatic vein, and right atrium all in the same image. The IVC is less than 2 centimeters in diameter normally, and it collapses by more than 50% with inspiration. When a patient breathes in, they drop the pressure inside the chest. They get that negative intrathoracic pressure that slurps blood up into the right atrium, and it causes the walls of the IVC to come together. This study just demonstrated that people measure it in a lot of different spots, but by far and away the most common site to measure IVC thickness and collapsibility is 2 centimeters away from where it joins the right atrium. Based on where you measure it is also going to collapse more or less. The closer to the feet you get, so this is down at the renal vein dump, we are going to see more collapsibility, and then the closer to the diaphragm you get, the less collapsible. This study took a look at how much variability is present because the IVC is moving. So with respiration, the IVC is moving up and down. It's also moving side to side. You need to keep that in mind when you use M mode to measure the collapsibility and thickness of the IVC because during the respiratory cycle, you're going to be sampling different parts of that vessel. If you're cutting through it obliquely also in your long axis view, you might have a false diameter as opposed to cutting through the largest part of that vessel where you get your true diameter. In short axis, the caliber of that IVC is going to change from cranial to caudal, and so you need to be careful also about making sort of blanket statements without kind of fanning up and down through the spot where you're sampling it. This study looked at how far it moves, and in the most dramatic examples, they were seeing the IVC move up to 4 to 6 centimeters north and south, so up and down as the patient was breathing. And then it was moving generally between a half centimeter and a full centimeter east and west or left to right with each breath. This study looked at different measures in the short diameter to assess central venous pressure, and they found that the ratio of short to long diameter was the most accurate for assessing central venous pressure. As the IVC is more elliptical, so with a short axis or a short diameter and a long diameter, what they saw was that the CVP was normal or low. So when you have a short to long diameter closer to 0.3, that's going to be indicative of a low CVP. As we get closer to about 0.5, or when that short diameter is about half of what the long diameter is, then we're approaching a more normal CVP of around 6 to 8. And then as we go over 10 on the CVP, what we're seeing is that short to long diameter is closer to like 0.7, 0.8. And then the closer it gets to 1, right, so the more circular the IVC becomes, the higher the CVP goes. This is an example of the anatomy we're going to see. We've got spine in the background. It kind of looks like a ski mask, and the spine is the mouth, and then the aorta and IVC are the eye holes. We've got aorta here, IVC, and then sometimes you'll see that left renal vein take off, as well as the SMA coming out of the aorta. The splenic and portal vein sort of tucking under the liver, turning into the portal vasculature. This is a very collapsed IVC. You're seeing with each in-breath, the IVC is collapsing completely. It's also less than 2 centimeters in diameter, so this is a pretty low central venous pressure. This is what that looks like in short axis. We've got that IVC looks very elliptical. That short diameter is much less than half of that long diameter. Here you can see the comparison of those two. So again, low volume state or hypovolemia, we've got a CVP of around 3. The IVC is much less than 2 centimeters in diameter, and it's completely collapsing with each respiration. In our normal CVP state, we've got less than 2 centimeter IVC, and it's collapsing about 50% with each in-breath. And then when the IVC is plethoric like this and totally distended, not really variable with inspiration, and you even see the hepatic vein in this image really distended, that tells you that the CVP is pretty high. Moving on to JVP assessment. This was sort of a novel method described in the literature recently. These authors took a look at the right atrial depth by assessing the depth of the non-coronary cusp of the aorta on a peristernal long axis view. So we've gone over the peristernal long axis. You're looking at the aorta here, and then basically just kind of the back of the aorta. The depth from the top of the screen to there is what they would use as that below clavicle depth when they're assessing JVP. And then they'd measure the height of the jugular venous column above the clavicle and add those two values together. And that would give them the right atrial pressure. They performed right heart cath on all these patients, and they found a pretty decent correlation between the right atrial pressure based on the cath and the right atrial pressure from their ultrasound estimate. So when you're assessing JVP with ultrasound, probe marker to the patient's right, which was my right, and we're usually measuring that right jugular vein. We're just tracking the jugular up in a short axis view until we can see it almost completely collapsed, so like right there. And then we're taking pressure off. Notice how the probe's coming off the skin, and you're seeing this artifact here because we're just trying to generate as little pressure as possible. Make sure it's not us squishing the jugular vein. From there, you can turn to a long axis view, and what you should see is this kind of wine bottle or bird beak sign. So notice how the jugular vein is pretty much collapsed. So we turn to a long axis view, and we've got the carotid right there, and then fanning over to the jugular. You can see the walls coming together here. So that's the meniscus of that jugular vein. From there, I'm going to mark that spot on the neck, and then you can measure from there straight down. So you would essentially like use a ruler up from the sternal angle, and then maybe a piece of paper or a straight edge over to see what the height of that column is. And that's it. So practice finding IVC views, look at it in short and long axis. You can try some M-mode measurements to get a thickness and also a variability with respiration. And then additionally try to find each other's jugular venous pulses and the height of that jugular venous column to assess right atrial pressure. And you can even try mixing in some peristernal long views and adding the depth of that right coronary cusp or the non-coronary cusp to get a more formal assessment.